Hello and welcome to Clinical Cases. Today we're going to be taking a look at Foundation Block Part 1, which will cover themes such as genetics, including us taking a look at Edwards and Patau syndrome and Down syndrome, and also conditions of prematurity, including bronchopulmonary dysplasia and respiratory distress syndrome. So let's start with just that. RDS is a condition that occurs in preterm babies due to the lungs not being fully developed. Now, when we say preterm babies, we're thinking about babies born before the 37-week gestational age. And when we say the lungs are not fully developed, we're thinking about surfactant levels not being as high as they should be. So surfactant levels naturally increase with gestational age, and surfactant synthesis starts around week 17 and constantly increases up until around week 37 when the baby is born. The aim of surfactant is to reduce surface tension. So naturally, if a baby is born before 37 weeks, they're not going to have as much surfactant, they're not going to be able to reduce the surface tension in the lungs, and therefore this is going to lead to RDS. Now, occasionally RDS can occur in babies that aren't born prematurely, and this is usually as a result of other risk factors, such as when the mother has diabetes, if the baby's underweight, or just in general if there's poor lung development, which could be caused by a variety of illnesses, both to mother and fetus. In terms of the consequences, the long-term consequences are what are more profound for this condition, so usually we see these patients going on to have chronic lung disease. And when these patients have got RDS, we see an increased respiratory rate, hypoxia and respiratory failings. It's important not to mix RDS up with ARDS. So ARDS is a condition that you can get at any age in life, whereas RDS is pretty much exclusively for newborn babies. It's also important to take into account cyanosis in the newborn, which is essentially what we're talking about here. But cyanosis generally in the newborn has quite a high prevalence, and overall 4.3% of newborns may require supplemental oxygen therapy because of cyanosis. So this RDS syndrome normally occurs in babies that are born before 28 weeks gestational age. So although we're thinking pre-37 weeks, normally if they're born past 28 weeks they have enough surfactant to sufficiently carry out respiration. However, below 28 weeks they've got such a deficiency of surfactant that this RDS cyanosis occurs. When we're thinking about differential diagnosis for these babies that have got cyanosis, we might be thinking about transposition of the great arteries, tetralogy of fallow and pulmonary atresia, and these will be covered in later videos. Next we have bronchopulmonary dysplasia. So this is a chronic lung disease where premature babies, usually those that were treated with supplemental oxygen at birth, require long-term oxygen. It's important to differentiate between old BPD and new BPD. So these are just definitions and terms which apply to the condition of BPD, and it gives you an idea as to how the condition has arisen. So old bronchopulmonary dysplasia indicates a form of airway damage, whereas new BPD indicates no injury, no damage, but it's actually as a result of processes that interfere with lung development. So be aware that prolonged high oxygen delivery in premature infants causes necrotizing bronchiolitis and alveolar septal injury, which then leads to inflammation and scarring in the lungs. And if you've got inflammation and scarring around the alveoli, naturally it's going to lead to hypoxemia, in other words, low levels of oxygen. The diagnosis for this can be done via pulse oximetry or even via chest x-ray. Next, it's important to talk about cerebral palsy. Now this is a kind of crossover with neurosensory block, and it'll be discussed more in that system block. However, cerebral palsy is a group of permanent disorders in the development of movement and posture. It is a non-progressive lesion or injury to the developing brain, and it's got multiple causes and clinical manifestations. Although it's a non-progressive lesion which doesn't change, it does progressively get worse over time. The causes can be broken down into three, so prenatal, perinatal and postnatal, with the grand majority being prenatal, i.e. before birth. With regards to symptoms, these can vary in severity massively from individual to individual, and we could be thinking about physical symptoms, for example where the patient has weak arms or weak legs, or if they're a bit too stiff or too floppy, or alternatively we could be thinking about milestones, how they're missed or delayed. In terms of treatment or management, really this is focused on management of cerebral palsy, so physiotherapy is really important, speech therapy to help with speech, occupational therapy, medication for any muscle stiffness and other difficulties, and sometimes some patients undergo surgery to treat movement or growth problems. Here you can see a fairly old classification of cerebral palsy, splitting it into mixed, spastic, aphotoid and ataxic, and diagnosis is via MRI, cranial ultrasound, EEG lab tests, and quite frankly clinical features, so looking out for these missed and delayed milestones and pretty characteristic signs in physical signs. We've got weak arms, weak legs, etc. Next we have periventricular leukomalacia. Essentially this is where the white matter of the brain becomes soft. So white matter is responsible for transmitting messages from nerve cells in the brain, and therefore if it's damaged it can cause problems with movement and other body functions. The white matter surrounding the ventricles of the brain, so that's why it's called periventricular surrounding the ventricles, it's deprived of blood and oxygen, and that's what causes it to become softened. It's not usually obvious at birth, however signs and symptoms usually become clear when the infants are around 1 or 2 years old. The most common symptom is cerebral palsy. A lot of these patients develop cerebral palsy, and remember how we said previously, cerebral palsy is a very variable condition. Some children have very severe cerebral palsy and some very minor. Children with periventricular leukomalacia may also have visual problems and learning difficulties. With regards to treatment and management, there isn't a cure or specific treatment as such, but steps can be taken to improve the sufferer's symptoms. Next we have Spina Bifida, so again this is a bit of a crossover with the neurosensory block and will be discussed more then. Spina Bifida is a type of neural tube defect. So this is thinking back to embryology, and being aware of the embryological origins of the neurosensory system is really important in understanding some of the conditions that occur. So the neural tube is the structure that eventually develops into the baby's brain and spinal cord. So the neural tube starts to form in early pregnancy and should close after 4 weeks of conception, following conception. In Spina Bifida, part of the neural tube doesn't develop or doesn't close properly, and this is what leads to the defects in the spinal cord and bones of the spine. So there are 3 different types of Spina Bifida to be aware of. These are Myelomeningocele, meningocele and Spina Bifida Occulta. So some of these are really severe. So Myelomeningocele is the most severe type of Spina Bifida, and this is where the spinal canal remains open along several vertebrae in the back, which allows the spinal cord and protective membranes around it to push out and form a sac in the baby's back. And this can be seen down here at the bottom, and this is the most severe form. Another serious type is meningocele. So a similar kind of thing happens here, where the protective membranes around the spinal cord, i.e. your meninges, push out through the spine. And the spinal cord normally does develop normally, so surgery can often be used to remove the membranes without damaging the nerves. The third type is Spina Bifida Occulta, and this is the most common and mildest form. And this is where 1 or more vertebrae don't form properly, but the gap in the spine is very small, so it's not as noticeable. Most people don't even realise they've got this form, as there are such few symptoms. This condition is most commonly treated via surgery for the more severe forms, particularly in those first few weeks of life. Therapies to help make day-to-day life easier and improve independence, such as physiotherapy and occupational therapy, are also used, as well as assistive devices and mobility equipment, such as wheelchairs and walking aids. Hydrocephalus is a build-up of fluid on the brain. So the excess fluid puts pressure on the brain, which can cause damage, and if this is left untreated, it can be fatal. There are different types of hydrocephalus to be aware of. So we have congenital hydrocephalus, so this is where it's present at birth, as anything that's congenital is. Acquired hydrocephalus, so this is where it develops after birth. And normal pressure hydrocephalus, and this is where you have hydrocephalus, but normally in older people, and we'll discuss this a little bit more in the neurosensory block. So CSF has got 3 important functions. It protects the brain from damage, it removes waste products from the brain, and it provides the brain with the nutrients it needs to function properly. So the cause of hydrocephalus is the buildup of CSF on the brain due to either a blockage or faulty overproduction of CSF or poor clearance of CSF. So these are usually the 3 most common mechanisms of the buildup of cerebrospinal fluid on the brain. The symptoms as a result are headaches, being sick, blurred vision and difficulty walking. So these are all things associated with damage on the brain or pressure effects on the brain. This condition is much more noticeable in babies as the size of the skull increases due to the cartilaginous fontanelles that are formed at birth and therefore it's more noticeable because the size of their head almost appears to swell. The treatment for this can usually be done with a shunt, so this is a thin tube that's surgically implanted in the brain and drains away the excess fluid. Sometimes a endoscopic third ventriculoscopy can sometimes be used as an alternative to a shunt. It's important to differentiate between non-communicating and communicating hydrocephalus. So non-communicating is another way of saying obstructive. So this is where there's a structural obstruction along the CSF pathway, and this leads to a build-up in the ventricles and the heightened CSF pressure. A communicating hydrocephalus is where there's an accumulation of CSF in these situation is due to impaired absorption. So we continue to produce, however we're not reabsorbing it back into the ventricles. And in older adults this syndrome is called normal pressure hydrocephalus. And the triad of symptoms to consider for NPH will be discussed further in the neurosensory block. Next we have a little look at genetics, so Patau's and Edwards syndrome. So Patau's is where we have an additional copy of chromosome 13 in some or all of the body cells, and it's also called trisomy 13. There's screening options available around weeks 10 to 14, and most cases are non-viable, and some are born as stillborn or miscarriages. So the symptoms here, we usually have growth restricted in the womb. 8% will have severe heart defects, cleft lip and palate, abnormally small eyes, and reduced distance between the eyes, and these clenched hands and polydactyly are also common symptoms. With regards to Edwards syndrome, this is trisomy 18, so you have 3 copies of chromosome 18 in some or all of the cells of the body. Again, there's no cure for Edwards syndrome. It's usually treatment focused on life-threatening issues that arise at the time. Usually these babies don't live for too long, the prognosis is pretty poor, and they rarely live past 1 to 2 years old. Symptoms for this baby, you tend to see a small abnormally shaped head, a small jaw and mouth, long fingers that overlap, low set ears, and smooth rocker bottom feet with a rounded base, as well as a flexed big toe. Next we have haemophilia. So this is a rare condition that affects the blood's ability to clot. It's usually inherited, and most people who have it are male. Normally when you cut yourself, obviously clotting factors combine with blood cells called platelets to make the blood sticky and cause the clot and eventually stop the bleeding. So symptoms of haemophilia tend to be when the patient is bleeding and they realise it takes a long time for the bleeding to stop, such as in a nosebleed. There's no cure for haemophilia, but treatment usually allows the person with the condition to enjoy a good quality of life. With regards to genetics, there's different types of haemophilia, A and B, and they're both inherited in an X-linked recessive pattern. So the genes associated with these conditions are located on the X chromosome, so therefore no son of a man with haemophilia will have haemophilia themselves. Usually all daughters of a man with haemophilia will be carriers, called obligate carriers, and if a carrier has a son, the son has a 50% chance of having haemophilia. So that's good to be aware of, as they're easy exam questions to test on. Lastly for this video we have Huntington's disease, and again this will be covered in a lot more detail in one of the later blocks. So Huntington's disease is an inherited condition that damages certain nerve cells in the brain. It leads to personality changes, mood swings, fidgety movements, irritability and altered behaviour. It's caused by an inherited faulty gene, but to be more precise, it's inherited due to an expansion of the CAG repeat length at the N-terminal end of a Huntington gene. And what's really to remember about that is the CAG repeat, that codon of which is repeated, which causes Huntington's. There's no cure for Huntington's disease and it can't be reversed or slowed down, but medication can help to manage the symptoms. Both men and women with a family history can inherit the condition, and symptoms usually start to appear during adulthood. That's everything for this video. Hopefully you found it useful, and thank you very much for listening.